looking at differentiating between some different things that go on with the pain experience. Again, pain itself is a physical sensation. When we look at some of the ways pain is perceived and some other issues with people's pain experience, there's some other things to consider. So when we look at pain, suffering, disability, again, pain's the physical sensation. Suffering is more of a cognitive social behavior. So there's different things that, again, need to be modified when you're dealing with this. And again, it's going to be important. The same thing with disability. Disability goes beyond just merely a physical component. There's, again, a cognitive, there's a mental, there's a sensory, and there's emotional things that go along with disability. And part of what the issue that we have and we need to avoid with our patients is the problems that kind of magnify this are passive treatments. And by passive treatments meaning that they are things that don't get the patient moving. If there's an inordinate amount of physical activity, which again, a lot of the modalities we do are passive. That's why that goes to the importance of combining modalities with whatever exercise you can. So basically the way to minimize this is to avoid having the patient be inactive, getting them doing as much as they can based upon what the injury allows. The multi-dimensional nature of pain perception, again, this is kind of keeping with the same concept of understanding the different ways that pain kind of gets experienced by patients. So it's kind of a different way of viewing painful stimuli. So we have different types of aspects as far as how pain is perceived by patients. So we have your common sensory aspects. And the descriptors of the sensory aspects are the common things that when you ask people to explain their pain, things such as throbbing, stabbing, sharp, stinging, are kind of the descriptors. So kind of is essentially what they're feeling as far as the actual sensation of pain is concerned. Then you have your affective component and some of the descriptors associated with that. This centers around either the emotional or the autonomic response to pain. So crying, things like crying, being anxious about the pain, different mental states, goals, desires. So it influences this. Obviously, if say you have a senior athlete, their senior year of high school, and they get injured, towards the end of the season, going into the playoffs, and they can't play anymore. Obviously, there's going to be an emotional response to that, influenced by the mental state of knowing that their high school career is going to be over. That could be something that ties into that. The evaluative response is kind of the conscious thought process about the pain stimulus. So comparing for instance, a current injury with a past injury. So again, there's a big cognitive evaluative response in regards to evaluating the nature of the pain that the individual is experiencing. And then the miscellaneous component is kind of just your book classifies the miscellaneous component as a combination of the other three. So for instance, descriptors such as an injury or a body part feeling cold, numb, tight, those are kind of like descriptors that it could kind of fall under a couple others. So in other words, the sensory description of tightness, it sounds sensory, but at the same time, there could be an evaluative component to that. So tightness relative to maybe what they were prior to the injury, or relative to how they felt with a previous injury to a specific body part. So looking at the overall, again, still looking at the overall pain experience, an interesting thing you're going to encounter is a great variability in pain tolerance. Again, looking at everything that encompasses what happens with pain, it goes beyond strictly just the structural damage. And you take, for instance, even just the pain tolerance of two people with similar injuries. Again, what they say their pain is could be very different from one to the other. And essentially what's happening here is other parts of the pain experience beyond just the sensory aspect kind of overrides or kind of takes over what the person explains. And like, for instance, you could have the affective component overriding the sensory dimension of pain. And again, part of what occurs with this is some of the past experiences the person has, or even their level of physical activity can sometimes influence this. Obviously, you have athletes who will play with injuries that would, severely limit somebody who is, maybe just with their daily activity, someone who is not quite as active. The other aspect of this is the learned pain experience that develops through pain memories. And part of what influences this, the learned pain, are some of the secondary stimuli, meaning that anytime pain is kind of coupled with other factors, for instance, environmental or social factors, will stimulate secondary pain stimuli. Inactivity will do this as well. So again, somebody who maybe injures themselves and then becomes very inactive or doesn't do anything while they're injured, that's going to influence, again, that pain experience. So other things, anticipation or expectation of pain, if pain resolution is delayed, those are all things that will influence that learned pain. And again, that will also influence future experiences with pain as well. So again, we're looking at things going beyond just the straight structural damage associated with pain. And the other thing is, pain is difficult to measure. We're going to go through some different ways we measure pain. The most common way we measure pain right now, or at least we attempt to objectify pain, is through pain scales. But again, even pain scales, what's a 2 out of 10 for one person could be a 4 out of 10 with another person, even looking at the same injury. So you have to look at it within the context of each individual person's pain experience. Now going back to some of the different ways in which we kind of control the pain experience, and this is actually one of the levels of pain control that we've actually already talked about and are going to talk about again. The descending endogenous opiate theory is essentially looking at operating at a supraspinous level. So in other words, the pain control mechanism descends from the brain down to the spinal cord. So if you look at the picture at the bottom, it's showing the difference between the two. The ascending, again, which we've already talked about, or what we look at as the gate control theory. Your basic gate control theory is large nerve fiber or A beta cell stimulation closing the gate to pain, whereas with the descending endogenous control or descending endogenous opiate theory, you actually stimulate the small fibers. So the T cell actually responds to small fiber stimulation. So what you actually do is stimulate the pain fibers in this model. What happens is the T cell responds to that through two structures in the brain, the PAG, or what's known as the periaqueductal gray region in the brain, sends information to the RAF nucleus in the brain, which then sends descending chemical messengers down, and particularly enkephalin and serotonin. And those substances then at the level of the spinal cord block the pain sensation. So this is an example of where you will actually use a treatment to stimulate the small fiber or the small nerve fibers or the pain fibers to actually induce a level of pain control. Looking at the central control trigger theory, this was basically a modification of the original gate control theory. So the gate control theory, the essential components of it are still there, but they found through research, again, some other aspects that become associated with pain relief at this level. Most notably, that in addition to the original gating mechanism that we saw, the other part of this, or the central control part of this, acts via the incorporation of endorphins and enkephalins. So we have two different levels or two different mechanisms of pain control in the spinal column. We have one local control mechanism and the one via the descending tracts. So this kind of influenced part of the slight change that occurred even in the original gate control theory, where we look to now incorporate not only the stimulation of A beta fibers and the closing of the gate, but also the incorporation of these naturally occurring pain modifiers, again, the endorphins and enkephalins, how they work in controlling pain. And take a look at concept check 8.3 on page 153 in your book, and just kind of as a side thought, read that. It looks at some TENS research and how how some of these different aspects of pain control get utilized. The neuromatrix theory of pain and pain control looks at, again, further aspects of the overall pain experience, and this was sort of another expansion of the gate control theory. Again, it looks at including the action of endorphins and how it affects chronic pain. The other thing this looks at is, again, that multidimensional pain experience. So in other words, what this theory kind of looked at as far as pain's concerned is that, again, pain patterns get influenced by things independent of sensory input. So when in looking at this, chronic pain, for instance, there are some issues with chronic pain that a person could experience chronic pain without any real physical stimulus. So in other words, there might not be an actual injury or inflammation or pathology, but somebody, based upon their past life experiences or some other psychosocial aspect of the injury, can influence someone's pain experience. So again, this further kind of complicates some of the ways in which we may have to deal with pain, where something other than someone's actual physical injury. So at the point where someone may almost be cured of the injury, they still may be experiencing some pain based upon other aspects outside of the individual sensory input. Looking at the types and classifications of pain, looking at, first of all, a lot of times pain is classified by location, so that's simply just either anatomical location or a body system involvement. So for instance, location would be, ankle pain, knee pain, low back pain. Body system, you would talk about vascular pain, you would talk about neuromuscular pain or neurological pain. So those are different ways by location that we typically classify pain as. The other thing we look at is duration. Now, when we look at duration as it strictly involves pain, don't confuse this with when we talked about care and the stages of inflammation. Don't confuse the two, okay? Because the time frames are going to be different in regards to the two. So here we're talking about overall pain experience. When we're talking about inflammation, we're talking about it as it relates to acute care and how we approach it. So acute pain is pain that lasts up to about a month, and usually less than a month. It's actually typically pretty short term because it specifically relates to the actual onset and tissue damage. So when we look at our injuries that have specific mechanisms, so an MCL sprain in the knee, a dislocated shoulder, that's going to be all acute pain. Subacute pain is pain that lasts from anywhere from 1 to 6 months and usually starts as acute pain. So this is where there still may be some healing going on. The injury is not totally resolved. Whereas with chronic pain is where it can start as acute pain, but this is your persistent pain that, again, lasts beyond when the injury is actually healed. Now, something is technically officially classified as chronic pain once it lasts longer than 3 to 6 months. And I would even say some chronic pain could be beyond 1 month. And this is usually something not specifically related to a particular trauma. And what they've actually found is in people with chronic pain, they have decreased levels of enkephalins in their body along with increased sensitivity of nociceptors. So again, a lot of this is going to be particular to your injury. Again, you could also have chronic pain from injuries that don't per se have an acute onset. So you have two aspects of chronic pain. You have chronic pain that could start as acute pain, and you have chronic pain that could start from an insidious or where there's no real particular time frame. Take, for instance, our case study that we did in the chapter on superficial heat, where the individual didn't have a particular acute injury. She just, I don't remember what the exact time frame was, but the patient had pain that started a little while ago, and she didn't have a particular injury associated with it. Table 8.3 in your book is a good resource, page 155. Again, it talks about things we've kind of already mentioned as far as the verbal descriptors of pain, the different nerve fibers that carry pain, and the types that they particularly carry. Another thing we have to look at is the manifestation of pain, and this refers to when you have pain occurring in an area other than the origin site of pain. So the two common examples there are your referred versus radiating pain. Referred pain is when you have pain other than a site of the actual injury or trauma. A simple example of this or when you have, for instance, your abdominal organ damage. So, for instance, when you have damage to the spleen or liver, those two organs refer pain, for instance, to the left and right shoulder, respectively. So, this is a situation where you have pain that gets perceived in another area other than where the actual injury took place. You could see this in a musculoskeletal example from the standpoint of trigger points. When you're on an actual trigger point or hyperactive area in the muscle, that will refer pain to other areas as well. And you'll see this when we look at trigger point therapy, how that kind of feels and how it refers pain to other areas. Now that's different from radiating pain. Radiating pain is where you actually have an irritated nerve root. So you see this a lot in low back issues, and people that have herniated discs that impinge on the dorsal root ganglions will actually cause radiating pain. So again, those are two terms that could sometimes get used interchangeably, and they technically mean two different things. So referred pain is just strictly pain that gets referred to another site from the actual trauma. Radiating pain is pain that travels along an actual irritated nerve root.